My name is Patrick Kelly. Here at the Institute of Medicine, I direct the Board on Global Health, as well as for the whole National Academies complex, the Board on African Science Academy Development. And I'm happy to welcome to the front table two of my African colleagues, Stefanos Simon from Stellenbosch University in South Africa, and Rose Nabiri from Makerere University in Kampala, Uganda. As you can see from your agenda, they represent two learning collaboratives that are affiliated with our forum. I'd like to explain a little bit about how these learning collaboratives came about, what they really are. Back in December of 2010, when the Lancet Commission report was released, and shortly after the Future of Nursing report was released, Afaf Melis, who will be with us shortly, encouraged the IOM to develop this forum. The two reports I just cited were wonderful blueprints for starting progress forward in exploring innovations in health professional education that could help us achieve the triple aims. But in many ways, those two reports, though inspirational, were written at the 50,000-foot level. There were recommendations in there, for example, around institutional improvements or instructional improvements, around leadership. And as far as those go, those are great ideas. But there was a feeling that much more conversation and exploration was needed to put meat on the bones, so to speak. So the goal of the forum was really to take those two reports and start to put some meat on the bones through this mechanism of this forum. So as you know, the forum is driven to some extent by the content of those two reports, but we are reaching out globally to understand how to, for example, build leadership capacity as just one example. We wanted to be more than what some would call a talk shop. In fact, the president of the Institute of Medicine says we want to not only be something of a think tank, but also a do tank, a think-do tank, to bring what we do down to the ground, from the 50,000-foot level to maybe the 5,000-foot level of this forum, right down to the ground, and explore how different types of institutions are pursuing on the ground the implementation of some of these recommendations. So with some funding from the Gates Foundation, we were able to issue a request for proposals that called for institutions to develop partnerships between a school of medicine, or at least a school of medicine, a school of nursing, and a school of public health. And they would take at least one recommendation in the cited reports and start to implement it with some feedback from this group, some back and forth. And as you know, in other countries, in some ways, they're constrained and benefit from the input from folks in a broader context. In other ways, what we might see as a constraint is actually liberating. Sometimes the lack of resources forces some creativity. Sometimes the lack of tribalism allows certain innovations that might be much harder to stimulate in a place like this. So we received, I believe, 12 responses to our RFP, and we accepted 4, one from Canada, one from India, one from South Africa, and one from Uganda. We heard yesterday evening from the Canada Collaborative, which turned out to become a collaborative of collaboratives. We originally were envisioning just one school or one university with multiple schools would apply, and as you heard, the Canadians have taken on a program that involves 5 major Canadian universities. Similarly, we were surprised by our colleagues in Africa. Stellenbosch University combined with several other South African universities to pursue work in the area of leadership development. And we heard in our planning session on Wednesday the great interest in focusing on leadership development. The Ugandan collaborative proposal came from Makerere University, but it also involved multiple Ugandan universities, and their focus is on professionalism and ethics. So we're going to spend the next hour, about a half an hour, hearing from Uganda and a half an hour hearing from South Africa on the work that they're doing. We'll try to allow at least 10 minutes for discussion of each of the presentations. So first I'd like to invite my colleague Rose to tell us about the Uganda Collaborative's work. Oh, by the way, for those of you who are tweeting, the hashtag to tweet is IHPE Forum, IHPE FORUM.
Thank you. Is it on? Good morning, colleagues. I'm Rose from Makerere University, Department of Nursing. I'm going to share our experiences as nursing in this collaborative, especially in IPE, and then I'll talk a little bit about the proposal, the collaborative proposal for IOM. Next, please. Am I the one to do this? Yes. All right, thanks. The nursing department started in 1993 to offer a 4-year undergraduate degree in nursing. Originally, the country was training nurses at diploma level only, and Makerere University was the first one, a public university, to introduce this program in that year. When the program started, it was started within the Faculty of Medicine then, which was easy for it to incorporate the IPE principles. How we conduct IPE at Makerere University, College of Health Sciences in particular, with the visionary leadership of Professor Nelson Sewankambo, who was then the dean, now his principal because it has become a college. We started the PBL program and implementing the interprofessional education with all the programs, the BSN, the medical students, the Bachelor of Pharmacy, BDS, and Bachelor of Biomedical Radiology. So they are taught together in the first 2 years, especially when they are doing biomedical sciences. And the students, each year, the intake is about 200 students. So they are divided randomly into groups for tutorials. And these groups have the nurses, each is a mixture of groups. And they go through the tutorials in the PBL. And they are exposed to clinical exposure early enough. Originally, it would be like the clinical years starting from 3rd year. But with this sort of training, we expose them early. And we also introduce the community-based education, research, and service, where we send our students in those groups the interdisciplinary groups to various units all over the country. We have more than 50 sites, which we call the community-based education and research service sites. They start from first year. During the first year, they go there like for 4 weeks to get familiar with the health system where they will be working, to see how the services are run, and they get to know that the health is not about the health director only, but also the political, like we have the chief administrative officers and the political wing of, they are called resident commissioners. So they get exposed to see them and how they, how you interact with people, and if you want a program, how do you, get these people on board. And during this training, all faculty, whether you are from nursing, BDS, or medicine, you are assigned a group. So we teach college students, not nursing students or medicine students. So the students belong to the college. So that's how we do it. And you don't have to be a content expert as the PBL is conducted. So they only orientate us in the PBL process, and then we conduct the teaching. So we don't feel that these are medicine students and I'm a nurse, I can't teach them. No, we teach just like any other. And as nursing, Nelson requested me to talk about how we feel as nurses about this sort of teaching. We feel that, as the student said yesterday, this sort of coming together nurtures collegiality. The students become colleagues from the beginning, and they are exposed to other, especially the nursing students, they are exposed to other professions' roles, which bring about the appreciation and respect, actually, for all of them. The medicine students appreciate the nursing students, because when we develop the problems, we sort of bring all aspects in this problem, so that when they are discussing, the nursing issues will come out, the medicine will come out, the radiology, and even public health, and so on. So it enhances students' understanding of the context and scope of practice for the different professionals. And we think with this sort of arrangement, the traditional stereotyping of, this hierarchy is erased. That's what we think. For the nurses, it has also provided an opportunity for diversification and specialization. We have had our colleagues, like from the sciences, physiology. Can you identify for me a smart student? I wanted her to do this master's in physiology, or pharmacology, and we have had them do that. And for us, we think it will really improve our teaching, because originally we were sort of begging, because we are not experts, and then you want your students to do the physiology. Now you have to go to this colleague, the professor, and request, can you take on my students? But now we don't have to, because it's our student. They feel they are obliged to teach everybody. And we no longer feel shy, because we have regular meetings on a weekly basis to see how the tutorials are going. And when we sit in these meetings, you don't feel that this professor of microbiology, you will not get intimidated. If they are not doing what you think, you tell them. And then you find that it has sort of created this equality, and it has also improved the image of nursing profession, because when we are in meeting or discussing, we are also able to to give our views, and our colleagues appreciate. And we also took on leadership, positions. Like, you may find I'm the chair of a certain committee of the college, and then the other people will, look up to me because I'm the chair. It's not that I'm a nurse or no, you are the chair of this committee, And you do your work and you call on these other people to do what you think they can do. And it has also helped us to optimize the use of available resources. For example, human resource, as I said earlier, we may not be content experts in certain fields. So when our students are together, then, we are not begging, they are taught equally. Issues of space, because we put them differently, they don't have to be in a big classroom. They are in small groups of between 10 and 12. So any space, even offices, are used as tutorial rooms. So they are assigned, you find that you just use any available space. Otherwise, originally, then you have to look for space. Where would I take my students to do ABCD? So these days, it's no longer there. As nurses, we have been inspired to advance in health professional education, because in the college, when there's an opportunity, everybody is given an equal chance. So if it is an opportunity for master's or PhD, they will put out the advert. Whether you're a nurse, you apply, and if you qualify, then it will be given to you. And it has enhanced interprofessional relationships. We do participatory planning and the collective decision making. So when we are about to begin a semester, we sit down as a college to see how we shall run the tutorials, which courses are being taught, who is the course coordinator, and you'll find that in some cases it's the nurses who are course coordinators, or a physician, or a microbiologist, or pathologist, or so on. And it has also increased the awareness about our roles and abilities and competencies in healthcare. So we are so happy about it. However, there are challenges. Sometimes we feel as if the nurses are losing identity, because some faculty, this business of college students, everybody may be called a medical student. When they go to the clinical area, they are called medical students, and yet we want them to have that nursing in them. So it's a challenge. Well, as probably we shall see how to solve it. And then retention of nurses. We are losing many to other health professionals, as I said, because after they have realized that they have the capability and potential, then they are being grabbed, especially the medical sciences, the biomedical. They are taken away from us, and yet we still want them. The curriculum design, we are yet to produce that one which is IPE, okay, which now brings us to the collaborative, because we agreed to develop and implement a curriculum, interprofessional educational curriculum in ethics and professionalism, with the aim of improving health of the people by having these future health professionals competent in the ethics and professionalism. Because of recent, why we chose that one, we have very many issues of ethical, malpractice. Very many times we find that doctors or nurses are being sued because they have not done what they are supposed to do. People take on, because of their situation in the country, you find that some nurse or doctor is working in the hospital and also running private practice, so they put very little time for the profession to work because they are looking for money. So we thought if we develop this curriculum and implement it, probably we shall be able to improve this sort of image and practice. And we are supposed to do it in collaboration with the professional councils, the medical and Dental Practitioners Association, the Uganda Nurses and Midwives Council, and Allied Health, where the radiology and others fall. So we are yet to develop this curriculum. The methodology, we thought we would invite all the stakeholders, first of all, to identify the problem, because we may think it is a problem when it's not. And after we have identified this problem, then we shall also try to we shall do another needs assessment and develop the curriculum. So far we have two committees, the Needs Assessment Committee and then the Curriculum Development Committee. So the Needs Assessment is doing its work, and then the Curriculum Development Committee will be informed from that needs assessment, and we shall go ahead to develop and implement this curriculum. Where the curriculum we want it to be for, we intend to develop two, one for the students, okay, and then another one for the practitioners, because they are not also doing the right thing. So we hope that when we do that, these ones who come out will have the competencies and also try to improve for those who are in service already. We have, through this IPE, we have also tried to develop e-learning facilities. When we send the students to their communities, for example, we give them the electronic books, articles, because some of these sites, as we call them, they don't have, you know, some of them may not even have power, or they don't have computers, but the college also has tried to facilitate these sites. We train the tutors in those sites who are normally like the what are they called? The head of the institution. It may be a medical officer, it may be a nursing officer, and we call them to the college. We train them. We take them through the tutorial process and how we are teaching, so that we expect them when these students are there, they can be helped. And of course, now we have this video and teleconferencing facility where we developed a skills training lab for all college students. Originally, now we would suffer, the nurses have theirs, and then the medical students and so on. So we have this one lab which is supposed to be for everybody, and of course the early clinical exposure, when we don't wait for them to go to the clinical years. After they have gone through, they can, you know, learn as a group what they can do, at least why they should take temperature, for example, if they have just started, depending on the situation. And the COBAs, we are so proud of it, the Community-Based Education Research and Service, because it was an innovation after it was sort of a social accountability issue, because Makerere University graduates were being criticized that they are so smart, they know a lot of science, but they didn't know how to communicate to the people, they didn't know the leadership, you know. So it was so terrible. But now in this PBL, we teach the students that they are sort of being groomed to be leaders, because in the tutorial, they select a leader, they have a scribe, and then they are taught that you have to listen to everybody, you have to give everybody a chance. The tutor is just there to, you know, to facilitate, to make sure that they are doing. So we think we are developing their leadership skills and communication skills. Thank you very much for listening.
Brenda? Brenda and Malcolm.
Thank you, Rose, and also to Angela yesterday for participating on the student panel.
Yeah.
One of the questions I have is you talk about the difficulty with the different professions being referred to as one, and I think that a fear of IPE early on with folks was that we would lose that individual culture that we each value. What are some strategies that you're using to make sure that the students from each discipline feel like they have their own culture?
Okay, do I answer to that one, so? Well, it's very challenging, but we try to talk to our students as a department, and to try to inculcate that this profession, that this is nursing, is a profession of its own. So we think that after they have separated, because they are only together for 2 years, in the 3rd year, then they come to the department and we are doing nursing alone. So that's what we are doing, but I think we are not doing really enough, and it's a challenge. We need some advice on this one. Yeah.
Malcolm.
I think my question, in a sense, follows your answer to Brenda's question. The IP curriculum that you're dealing with is in the first 2 preclinical years.
Yeah.
And that's where you're losing some of the students, as it were, to other professions. I would argue, just as an aside, that that's not a loss. They're becoming health professionals of some sort. And I would imagine that you're gaining some students in nursing who are not initially identified as nursing. So that's one question. But my other question is, do you follow these students through their 4 clinical years? And do they then work in silos, in isolation, as single professional groups of professionals? Or do you have an interprofessional set of curricular objectives during the clinical years to continue the terrific work that you've been doing in the first 2 years?
Thank you for the question. I think this one, even the student alluded to it yesterday. We have not yet developed that sort of mechanism to follow them up as a group. And I think it's one of the challenges which I should have said, because we have not even done an evaluation to see how they are doing after they have graduated. But it is also a policy issue. For example, there was no recruitment. They have just started recruiting nurses and even doctors. So when they graduate, then they just have to go their way to look for jobs. It is only, although we have great shortage, there was this policy issue of not recruiting anymore. So then we lose out how to follow them up. So it's a challenge.
Thank you. Just following up this conversation, I think one, and reflecting on the Canada presentation from yesterday, one of the challenges that I think that maybe you're encountering, and that all of us will encounter, in the interprofessional education environment, how much will we try to maintain the borders of our own individual professions, and how much will we see ourselves as becoming interprofessional health care providers and educators. I think probably all of us, if we were to come at it from our own individual discipline backgrounds and say, oh, we're losing some of our people, it'd be great, just as Malcolm suggests, if we can all of us, both us as educators and encourage our students to think of ourselves really as being, as sharing these tasks and allowing blurriness between the borders of our individual disciplines and seeing that as a positive going forward, ways to turn that into real positives.
Thank you for the comment. I think I don't have to respond to that. Yeah.
So what I always say to my colleagues internationally is, please don't make our mistakes from the United States. Make your own mistakes, but learn from our mistakes. And we made lots of mistakes. Nursing profession is is different than other professions because of the status of the profession in the country, because of the stigma attached to nursing, and because of the compensation. So we have to take that into account in insisting in developing a sense of identity to nursing, to stay in nursing first. So 2 mistakes we have made here. We said the first 2 years are general education and then come to nursing, and we lost in that. So now we know that we immediately have to put students in a nursing clinical experience to develop that sense of connection to the profession, and that had really worked. Once you have that, then you can have the interprofessional part. The second mistakes we made is for the PhD students, they went into physiology, sociology, and psychology before we had PhD programs here. We let them do that. They never came back into nursing. But once we developed the nurse scientist program to bring them together to develop that continuous sense of identity, they came back and made a difference. So for nursing, it's just really different at its beginning in so many countries. You have to have that experience at the beginning of developing a sense of identity to the field and commitment to the field and be attached to it. Then you can become interprofessional and stay in the profession.
Thank you.
Is there one last question? I'd like to pose one last one, and maybe it can be addressed for the second presentation as well. One thing that we are very interested in is social accountability, how you select students to be responsive to the needs of society, to look at their profession as more than a way of generating income. And I'm curious, as you recruit students for the professions, the health professions in Uganda, what criteria do you use to identify students so that they will hopefully not only be scientifically competent, but also socially accountable?
Thank you for that very challenging question. Actually, the selection is a problem because the university just selects according to the grades. They must all have done sciences, biology, physics, chemistry, math, and so on. And then when the students, so many pass, the entry requirement goes up a bit depending on how they have performed that year. And what we have realized, especially in the nursing, most of the students, when they come, we call them in the department because this first year, actually, they are college students, and sometimes we don't even know our students. So we invite them to the department as nursing students, and we ask, was nursing your first choice? Because they put choices. And most of them say no. They had wanted to do medicine. And because of this traditional hierarchy, now if someone has not made it to the medicine, then they will take to nursing or these other programs, dental surgery and so on. So we get, especially for the nursing, it's a very, very big challenge. I find in my office girls and boys crying, oh, I want to change the course. Or sometimes some of them, because for the science courses, the government pays. And if you had wanted medicine and you are pushed to nursing, but you want to do medicine and you can afford, sometimes you'll be considered, So that makes it, still puts us at a disadvantage because we are thought as if we are failures. And then they come and we put them together. In these tutorials, they do the same, they go through the same things, and sometimes they perform better than the medical students, and they are feeling, but why am I in this nursing? So it's a very big problem. We were thinking of maybe conducting interviews. The university has started its own, the Faculty of Law, which has started with the interviews. But when we think of interviewing people, we may not get them because at present the image is not so good. So we are faced with that challenge. For law, everybody wants to do the law. So very many, even if they say you are going through an interview, they get so many applicants, they pay this much money to make sure that they are doing the interview to join. For us, when we start, I mean, the other universities will even take the private universities, because for them, they just select. Now for us, public, with these stringent policies and all that, we are at a disadvantage. The other thing is that we don't even recognize nurses who have already been practicing in Makerere. So if you want to come and do a BSN, whether you have been working for so many years, you'll do 4 years. And that one has really put us in a disadvantaged position. So we find these people going to other universities, the private ones. And then we remain with these young ones from high school with no, with this sort of feeling, I wanted to become a doctor, and now I'm a nurse. So we are trying to counsel. We do a lot of counseling, and we have got some who have changed, and they really come back and say, Dr. Rose, thank you very much. I'm now happy, and I don't think, we have got some who are like that. But then there are also others who have finished nursing, and then they go back and they apply to go to do the medicine, even if they did the first 2 years together. So they, it's such a sad situation.
Thank you very much. I Thank you. And Stephanos, would you like to update us on the work in South Africa?
Thank you so much for the opportunity to be here today. It's really a privilege to learn from you and to share what we're doing in South Africa. Our collaborative exists out of 3 universities: Stellenbosch University, the University of the Western Cape, and the University of the Free State. Myself, I've been involved, I'm a qualified medical practitioner with an occupational health background and a medical educationist. I've been involved in partnership development and facilitation on community level in Africa for the past 20 years. And for 5 years, I also worked for an IT company. We were consultants for UNICEF and MSF, among others, to see how we can use web-based technology to improve healthcare and promote health in disadvantaged areas, which were quite fascinating. And in a sense, this project that we're involved in brought together all of those things. So for me, it's a dream coming true. And I think that's why it's such a big privilege to be here today also. Just to remind you of the 2 projects our collaborative has. The first one is to identify relevant competencies that's required for collaborative leadership and to design and implement a suitable leadership program for health teams. There we work closely together also with Canadian revolutionaries. You've heard more about that last night. And the other program is to design and implement a competency-based interprofessional program for team skills in a community and primary healthcare setting. And I'll share more about that and the progress that we've made during this presentation. Just to quickly recap, if those of you who were not here last time, our IPE strategy is not for the sake of IPE. We really want to be socially accountable, and we see our IPE strategy and IPE as a vehicle, as a tool to develop agents of change, to really make a difference, to improve the patient outcomes, to equip our students as agents of change, also to strengthen the health systems in Africa. We believe that IPE can really be a vehicle for transformative learning and as an instrument to foster the interdependence in education between the health and the education systems. our IPE strategy is based on 3 pillars. The first one is to integrate graduate attributes, or what you will call core competencies, or the CANMEDs, into our curricula, and to assess that, also interprofessionally. The second pillar is to use the WHO ICF framework, or the International Classification for Functioning, Disability and Health, as a common language between all professionals in our faculty, or in our we call it faculty, for you faculty, staff, in our school, as a common approach to a patient and to managing a patient. And the third is basically leadership development, to equip faculty and facilitators of learning, preceptors out in the community with interprofessional skills, and to see how we can bring them together to work together. So just to quickly recap the ICF as a framework. The ICF framework creates the ideal opportunity for the biopsychosocial spiritual approach to patient care. And it gives us the opportunity that students and faculty, in approaching a patient, take all things in consideration for the holistic management and approach. It includes the body function and structure, the typical biomedical stuff that we all know, the activities and the activity limitations, the participation restrictions, the personal factors that involves health, and also the environmental factors. And to take all of those things into account in drawing up a management plan. And obviously not one profession on its own can do that. You need one another. And in using the framework, students and faculty realize, well, I can't do this alone. We need one another, and they start working together. So what happened since our last meeting? About 2 months ago, we went to Brazil to the WHO Congress and series of meetings on the family of international classifications. And in the first meeting, the first session, they were about to approve a guideline in using the ICF. They've been working on that for 7 years. And just before they approved it, I was mad enough or bold enough to raise my hand and to say, do you have 5 minutes so that we can share the results of our study? We did that, and the co-chairs stopped the bus. They said, well, we must include this in our guideline because this is of strategic importance. So the following is currently in the draft that hopefully will be published within the next month or so. They say, how can the ICF be used in interprofessional education? Interprofessional education task shifting and task sharing are key recommendations by Frank et al., of which all can be facilitated, through the use of the ICF framework. Examples of how the ICF framework can be used in interprofessional education, collaboration and practice include comprehensive outpatient clinics, ward rounds led by an interprofessional team, and joint community-based service learning activities. As a result of this, and thanks to the Global Forum, we were invited to join the Functioning and Disability Reference Group of the WHO and the Education and Implementation Committee as consultants regarding IPE. And a few internationally, a few people or organizations would like to join us to collaborate on this project. Universities from Brazil, Italy, Australia, and South Africa, the World Federation for Physical Therapy, and WONCA, and hopefully a few others after this meeting. Our pilot study over the past 2 years took place in a rural environment, Stellenbosch University's Rural Clinical School. And we found that by using the ICF framework, transformative learning took place. The health systems in a community setting and primary hospital setting, the health systems were strengthened. And interdependence between the health and education systems were nurtured. And The facilitator of all this, that brought this together, was this interprofessional assessment of students in their approach and management of a patient. Students in the settings where they were placed had to approach and manage their patients using the ICF framework. And then they had to present this to faculty and to preceptors as part of their assessment. And we invited a lot of health professionals working in those clinics to come and sit in on the assessment. We sat around a table, the students presented their case, and all of them were given score sheets and they were asked to assess the patient. They didn't have a clue about the ICF. They were just asked, just do it, just assess them. And afterwards, we will discuss the student's presentation, and we will come to an agreed upon score or mark. Within 3 months, the people at that clinic started to work together using the ICF framework because they realized we have to be role models for the students. They're way ahead of us. And more and more of them started to join in on the assessments. So it wasn't only summative and formative assessment for the students, but also for the preceptors. We are also in the process of extending the study within South Africa. More and more departments from our university are getting involved in the study and using the ICF framework, and also from the University of the Western Cape. In the coming year, the University of the Free State, KwaZulu-Natal, and Cape Town will join us. Another interesting development was that we were asked by 6 institutions, either faculty at the different universities or staff and the Department of Health in various clinics and municipalities to come and conduct a short course of how to use the ICF framework in IPE and IPP. 78 health professionals attended that over the past few months. We had 3 sessions over a period of between 6 weeks and 3 months. The first one, we gave an overview, why using the ICF and why it's so important, not just for teamwork, but in the bigger picture, the 50,000 feet paradigm. In the second session, they had to present in health professionals, in teams, a patient that they assessed over the past 2 months. And during the third session, we joined their team on an interprofessional ward round. As part of their assignment, they had to make their patient notes using the ICF framework. And the last assignment was to write a report to the Director of Health to motivate why the ICF framework should be used in that specific area. The result of that was that 1 district municipality are now planning to implement the ICF framework as an approach to patient care. And they want every health professional to use this so that people can work together. Here's just an example of patient notes. In 2 hospitals, staff started to use the ICF framework to record their assessment of patients, their management of patients. In the front of each patient file, there's this huge sheet with an empty ICF framework on it, and everybody makes their notes on this sheet of paper. So with a bird's eye view, you can see what's going on. That's the nurses, the physios, the OTs, the doctors, everybody. So what are we planning for the year that's coming? First of all, we plan to extend our pilot study to a more comprehensive study, including about 5 universities in South Africa. We are looking for more international partners, apart from the WHO partners, to join us in this study. Okay, you can put up your hands now. We are going to continue the tedious task of change management to convince faculty that we need one common approach to patient care if we really want to succeed to work in a team. There's no sense that the physio and the family physician, the pharmacist and the nurse have different approaches, different languages to approach a patient and manage a patient. And then obviously to find funding for our research. Lastly, I would like to say that our collaboratives, the 4 international collaboratives, are planning to meet in November next year in Stellenbosch, because we're now a collaborative of collaboratives, as a pre-conference to the 5th International Symposium on Service Learning. So those of you who would like to join us in our deliberations, you are more than welcome. Thank you so much.
Thank you. It's so exciting to hear that we have a collaborative of collaboratives of collaboratives.
Causing a pandemic, as Surita is saying.
Yes.
Thank you very much. This is very interesting. It would help me, and I don't know how many other people in the room are not familiar with the ICF framework itself. It would help me if you might explain it a bit, and just how do you integrate the ICF framework into care, actually, a little bit more.
The ICF framework can be used in 3 ways. The one is for individual patient care. The one is in public health to evaluate systems. And the other one is in social care. So,
sorry, could you even define what the ICF framework, what ICF is?
The ICF was developed by the WHO. Mm-hmm. You will know the ICD-10.
Yeah.
Okay, that's for making a diagnosis. They developed the ICF to primarily code functioning. So you can have a heart attack, which is ICD-10, I'm not sure what the code, but you may be fully functional and can go back to work, or you may be disabled. Okay. So for the different components of the framework, there's different sets of codes. We're not using the codes at all. We're just using the framework. So if you assess a patient, from taking the history to examining the patient and to draw up the management plan, clinical and non-clinical, you'll focus, and this is not a linear process. It's an iterative process because everything influences everything. It will be body structure and function. Well, you have a heart attack. So that's basically the heart. It's the heart. How are you going to manage the heart defect? The blood pressure, the cholesterol, things that we know, okay? Then how does this impairment affect the activities of this patient? If it's a stroke patient, can this patient still communicate, express themselves, dress themselves? How does this influence family life? So it's the activities, which obviously if you're in rehabilitation, out you're a physio, this is obvious, okay? For medicine, this is rocket science, believe it or not, okay? When it comes to participation restriction, can this patient go back to work? Did you phone the employee and say that the patient is sick and they can't just fire him, he must go on sick leave? We don't do it. Somebody will do it, but who's the somebody? So the idea of the ICF is that part of them must be a conductor of this orchestra, and this may be the nurse or the physio or the doctor, depending on the situation. And by using this, we realized, and in some instances in a stroke patient, initially it will be the medical student or the doctor that takes the lead, and later on it will be the physio or the nurse. And it's sort of a natural development. We thought it will be artificial, but it's not. The personal factors that influences this patient's health, so the coping skills and all those things. And then the environmental factors, which boils down to the public health factors. On one hand, it will be the physical environment, the house, the access to the house, the social factors, the relationships, the support. So environmental is outside of the patient. The patient does not necessarily have control of it. The stigma and the systems and policies that has an influence on health. So if you have a patient with a stroke who must be in a wheelchair, but it's not the right wheelchair because the government only gives one type of wheelchair, that's a policy problem. So if the student, as part of his management plan, can't tell me what are they going to do to advocate for other wheelchairs in this hospital, they didn't fully manage this patient. If there's stigma attached, or there's a lot of people with diabetes, are you going to start with support groups? What programs are you going to run in the community? So that's the ICF. And by doing this, you see what are the gaps in your system. And that's how we started to realize, well, health systems are strengthened. We didn't think of this at all in the beginning. But this is what's happening in a few places.
I see 3, 4 hands now. Afaf, Warren, Lucinda. Gosh, I'm not sure if we can do all of them. And John, I better write this down. Let's start with Afaf.
Thank you so much for this presentation and for the work you're doing. I love this because it's integrating medicine, nursing, and a number of other disciplines. So I have 2 quick questions. One, how long does it take to assess a patient in terms of time using this framework? And number 2, have you thought of putting it in a computerized health record? Because we have a number of those actually that combine many of those factors. And I don't know if you have compared them with the existing ones or you're planning to develop one.
Regarding the second question, we thought about it, but we're not sure even where to start, okay? So thanks for helping us on that one. We'll talk afterwards. What was the first one again? Oh, how long does it take to see a patient? If you're a third year, 2 hours. If you're a practitioner, 5 to 10 minutes. Because, I mean, you know what's relevant. We don't examine a patient on everything. When you have experience, it's like driving a car. You know what's relevant for this patient. 1 in every 10 or 20 or 100 patients, you know, well, I must spend time here because this patient came back and back and back. We have one example where we're actually in trouble with hospital management because they want patients out of the hospital within 3 days, and we kept a few patients for 7 days. The reason being, by doing an ICF ward round, or based on the framework, we realized that this patient comes back every month. We never sort out their problems. We just treat the hypertension or the fit, the convulsion. So let's sort out all these factors. And they're not coming back. We've solved the problem.
Warren?
Just a quick question. Very interesting presentation. And I'd raise a question to you and to the group around taxonomy. Should we begin to try to have a taxonomy that is beyond ICD-10 and also ICF that actually combines everything we need to know in order to take care of patients? I'm impressed as we try radical redesign of hospitals. A big barrier is that the professions use different diagnoses for what their problems are.
And I think that's what the WHO did over the past, I mean, this took 25 years to develop. And it's really addressing every aspect of health, not just a condition. And there's a code for it. You can actually do research on it and measure your progress if you start using the coding. So they've thought, and it's an international effort, to come up with this integrated taxonomy for everything that involves health.
Lucinda?
So the overachievers among us would, in designing the curriculum, want to teach everyone everything. And I can sit here and look and understand why it would be important for pharmacists to appreciate the context, but not be experts in fill in the blank. Any thoughts in terms of curricular design and application of how you avoid that tendency of making us all experts in every dimension of the framework?
We all are not experts. We all bring something specific to this framework. The doctor and the nurse will be on the body function and structure. The rehabilitation sciences will be on activities and participation. The nurse are the one who knows everything and can inform us because they're 24 hours a day with a patient. The psychologist, the counselors know more about the personal factors and can zoom on in that. The environmental factors, we all need to take cognizance of that because those are the things that's the barrier for the patient getting better, because it influences the health outside of the facility. So we must know about it. But it's often the occupational therapist will address those things, or the social worker, or the lawyer. Yeah.
John?
A comment first. I work with the complementary alternative medicine fields, and part of the way that I think these fields were invented was actually because consumers were interested in their functionality, and they weren't getting something from the mainstream system that was supporting them in functionality. And as we've worked with our research folks, that as an outcome is something that they've said, we want to see more kind of real world health services sort of functionality outcomes. I wonder, I mean, to all of you, what the barriers are to this framework in our system. It seems to me to be a kind of a wonderful, as you describe it, way of manifesting what the Lancet report is calling for in terms of connecting to the community, connecting to public health. And I would say, following up on our breakout session yesterday and looking at the role of the employer purchaser in pushing for stronger connection between the academic community and the delivery community, that the employers care about functionality. They've developed methods for measurement around presenteeism and productivity that are not generally even considered in our research community in medicine, which is a barrier to integration. But to bring this focus on functionality in may be a way to begin to move medicine out of the challenges it's had because it's been in an ivory tower.
That's health.
Yeah, exactly. That's health. So I think that there's just tremendous value in this framework in getting out of some of the reductive thinking we've had. And I think that you all know more than I about what the barriers are, though, to bringing this framework into your delivery environment.
Thank you. We have about 2 more minutes. Let's go with Susan. Maddie, were you in line too? Okay, Susan and Andre Jacques.
It's a pleasure to share a microphone. Thank you. Thank you. Thank you so much. I was very intrigued about the guerrilla approach, if I understood correctly, of doing this with the students in the rural school, and then the preceptors' clinician teams seeing the value and adopting it. And it reminded me of Lucinda's question about the way we approach things as educators and the way we think of faculty development, which could have just burdened everyone, raised their suspicions, et cetera.
And now they're requesting it, actually.
Yes, this is such a wonderful example of different ways to get to the same goal, especially in practice. Could you say more about whether this technique is now starting to spread to the others in the locations of the collaborative, or is there enough time that you can see what the students are doing as they start to go out into new areas?
Yes, our results show that students after a year are still using this. It's difficult when they come back to the tertiary institution because they don't see it there, but they don't like what they see in the tertiary environment, and they say that, okay? So they are starting to bring about the change back in the ivory tower. The other university, with the University of the Western Cape, they're starting with it now. Within quite a few, where's that? You can see nursing, physiotherapy, OT, social work, natural medicine, and pharmacy. So they will start using that in this project, also in their rural rotations, because we believe there you can do it, out of eye, out of sight. Do it, prove your point, and the students will bring back the change. And when we have the proof, we can start. We are busy with the change management back home.
Thank you. We're running a bit over, but I promised AJ you can have the last word. I'm sure Stephanus will be well visited during the break.
Yes, well, thank you very much for this exciting presentation. I am sorry that the dean of a school from the Philippines was not able to join us, Dr. Siega Sur, because at the School of Health Science in Leyte, part of the University of the Philippines, they are using the ICF.
Wow.
What I wanted to ask you is if you could maybe elaborate a little bit about the process of who is leading the orchestra, as you mentioned.
Whoever takes the lead.
The process, in other words, you have really, it's a wonderful IP tool.
Yeah. Obviously, it's not realistic that everybody can see a patient together. So initially, a doctor or a nurse in a clinic or a home-based carer, community worker, or a physio will see a patient. They realize when they do the ICF and approach the patient, where do they need others to come in? They'll get them in. They'll start discussing this condition. And out of that, the most appropriate person, the primary contact, not necessarily the primary contact, but the person who must bring the most value now will be the conductor of the orchestra. It just developed like that.
Thank you, Stephanus and Rose. You've really gotten us off to a wonderful start this morning.